So welcome to tonight's webinar, everybody. I can see people are already engaging with the chat, and that is excellent to see. So welcome aboard. So got something really special for you tonight. We've got David Metcalfe, who's a clinical lecturer in emergency medicine at the University of Oxford, with a particular interest in high-risk clinical presentations. He was elected as a Hunterian Professor, so I had to Google that one despite being an assessor for the Royal College, and congratulations on that. And was awarded a National Institutes of Health and Care Research Advanced Fellowship in 2022 to deliver the Cauda Equina Syndrome Early Recognition Study. I think I've got all that right. So for those of you who may be new to our presentations, firstly, welcome. So some rules for you. We have no idea what you're doing. If you're watching this in the bath, we do not know. If you're having your tea because you've just got enough shift, again, we don't know. So please interact with us in an appropriate way. If we're just having a general chit chat, feel free to drop it into the chat. And those of you who have been doing that, it's excellent. And it's really good to see that we've got some people from all over the country, all different types of professions, and in fact worldwide. So that's great to see. If you have any specific questions for David about his presentation tonight, then please drop it into the question and answer session, the question and answer section. As you can see, it's getting really busy in the chat. So we don't want pertinent questions to get lost. So please drop it into the question and answer section, and it'll just allow us to keep tabs of that, and then we'll address them all at the end. For those of you who are premium members of CPD.me, as always, you will get your certificates within 24 hours of this broadcast. If you're not a member of CPD.me, now is the time to get your phone at the ready and the ability to scan a QR code. That is your 30-second warning, because we've got something exciting for you coming up. So certificates and evidence, as always, will populate into your CPD portfolio, and then from there you can go in, add a reflection, and that's your reflection done. Use the app, use the speech to text facility, and it will take you a couple of minutes, rather than filing it all the way going, I'll get to it, and then that time comes where you get the curly finger from your registrant body and you've not done it. So stay on top of it. If you're rubbish like me, this is the simplest way by far. And always, accessing the recording will be available via the dashboard, usually within 24 hours once we've had time to edit me out and make it all about David, because let's face it, that's who you're here to hear. That's who you're here to hear about. Please get social with us. If you are on social media, head over. So we're on Instagram, we're on Twitter, and I'll be monitoring the Twitter feed tonight. And we've also recently taken up TikTok. I'm not doing any funny dancing. I'm Welsh. I can't dance. I can sing, but I can't dance. So there'll be none of that going on. If you send us a selfie of yourself during this presentation and pop it onto one of our social media channels, then the team will troll through them tomorrow, and will probably, if you're really lucky, end up sending you a CPD mug that you'll be able to be the envy of all your friends when you're on base, in work, or wherever you do work. If you're like me and you struggle to record your CPD.me, if you struggle to record your CPD, then CPD.me is for you. So 7 reasons to become a premium member. Very simple to use. Access all of our live webinars, and you get all of the recordings. You get automatic CPD certificates to prove that you were actually here. You get unlimited storage, so you can upload all your thank you letters, all your pieces of work, all your reflections that you've previously done. It can all be uploaded. We can scan it via the mobile app, so there's no need to sit in front of a computer and start scanning for ages and ages, because let's face it, NHS IT does not work. So use your phone and make that simple. As I've already mentioned, you get all the previous recordings of CPD.me. They're all on the back end. Fabio's done an enormous amount of work in sorting them and making it nice and simple for you to access them. So they'll all be there for you. And then it'll be perfectly formatted, whatever your profession is. If you get the curly finger from your registrant body, and bearing in mind HCPC paramedics, you're going to be getting your letters in the next couple of months saying that you've been pinged for audits. So make sure you stay abreast of your CPD. Feedback, as you know, is very, very important to us here at CPD-Me. So please leave us a honest, genuine review of the webinar, the work that we do, our product, whatever it might be, either on Trustpilot, Google reviews, or via one of the app stores. If you do that, we will, in the office tomorrow, we'll look at who's left us a nice review. We'll put you all into a pot. We will draw 2 of you out, and there'll be a chance for 2 of you to win a £25 Amazon voucher for your reviews. So a little bit longer than 30 seconds, but if we've got any students on board, and it doesn't matter what type of student you are, if you are a student with a .ac.uk email address, then we are giving you free premium membership of CPD-Me. Yes, that is free. So with your phones now, scan that QR code that is on your screen, or go to cpdme.com/student, and you will get the free product for the duration of your studies, because we're nice like that. But be mindful, this isn't going to last for long. Okay, so share the information, share it with all your colleagues, your classmates, share it with your university staff. If they want to get in touch with us and find out how we can onboard the whole of your year, get them in touch with us, and we will quite happily sort that out. All right, so 3, 2, 1, and the slide is going. So unfortunately, I'm definitely not Andrew, so Andrew can't be available tonight to host the webinar. So we do have a video from him, which we'd like to share with you now. So please take 30 seconds to listen to this, and you'll be very excited if you are not a member of CPD-Me.
Hi, my CPD seeking friends, and thank you for joining us tonight for this webinar. I'm leaving you in the capable hands of John, because unfortunately I'm away this evening, but as a little special treat, if you download our mobile app by scanning this QR code or by going to the App Store and searching for CPD-Me within the next 24 hours, I will send everybody who attends this webinar tonight a free, yes, free CPD certificate, so that when you download the app, you can see exactly what happens to that certificate, that you just need to then go in and reflect upon your learning journey. And I promise, guarantee, it will make recording and managing your CPD simple for the rest of your career. Any questions? Ask John. I'll be back next week, and thank you so much for your continuing support. Make sure you download the app and you'll get a free CPD certificate for tonight. Take care.
My name's David Metcalfe. I'm a clinical lecturer in emergency medicine, which means that my week is divided between 2 quite different settings. So half of my time is spent working at the John Radcliffe Hospital Emergency Department as a frontline emergency department doctor, and the other half of my week is spent in a much more genteel environment, working at the university, trying to think about how we can deliver emergency care more effectively. And as John said, I've got a particular interest in high consequence diagnoses that we need to make in the emergency department. So what we're going to do is talk about Cauda Equina syndrome. I'm sure this is something that most of you have encountered at some stage already, and you will know that this is a time-critical emergency that can be challenging to diagnose in the emergency department for various reasons, but that leaves a large number of patients, permanently disabled every year. So I know everybody enjoys anatomy, so I thought we'd start off with a little bit of revision and take it back to the bare bones, so to speak. So you'll all remember that the vertebral column is made up of a number of individual bones, the vertebrae. There are 7 vertebrae in the neck, the cervical vertebrae, 12 in the thoracic spine, which articulate with the ribs, 5 in the lumbar spine, so this is towards the bottom of the spinal column. Then there are a number of fused bones that make up the flattened sacrum, and then the tailbone at the end, the coccyx. And in between the vertebral bodies, there are these intervertebral discs, which are fibrocartilaginous structures, which are composed of, have got two main components. They've got a fibrous ring around the outside, and then on the inside of the disc, the center of the disc, is made up of this soft gel-like nucleus, the nucleus pulposus. And importantly, running down the vertebral column within the vertebral canal is the spinal cord. And the spinal cord gives off nerve roots at each vertebral level, which you can see on on each of these pictures in yellow. And they're paired nerve roots, one on the left and one on the right. One thing that you will be very familiar with is patients who present with radicular pain, often in the lower limb as sciatica, which is commonly caused by a prolapsed disc, which you can see over in the picture on the right in red, pressing on one of those nerve roots. And that causes sciatica, which can be pain in the distribution of that nerve root, but might be paresthesia, might be numbness, or might even be a motor deficit, so weakness. But the spinal cord stops in adults at around the level of the second lumbar vertebra, so L2. But the spinal cord doesn't just stop, because it continues, or at least the nerve roots that make up the spinal cord continue as this Cauda Equina. And this 17th century French anatomist first described the spinal cord scattering like a horse's tail, which is where the Cauda Equina comes from, the horse's tail. So why have we all chosen to spend our Tuesday evening sat talking about Cauda Equina syndrome when there are lots of other things we could be doing instead? And I've said already that it's important to patients, because lots of patients are left permanently disabled by this condition every year. But it's also important to us as clinicians, because it's a huge challenge for us to diagnose. There are a number of reasons for why this is a really challenging diagnosis. The first is that the pool of patients that we need to consider this diagnosis in are really all patients who present with back pain or radicular leg pain, so sciatica. And this is a huge population. We know that over 1 million patients book into UK emergency departments every year. It's over 1 million patients with back pain alone. And there are only 2,000 cases of Cauda Equina syndrome in the UK every year. So we're very much left looking for a needle in a haystack, just a very important needle. The second reason why we don't diagnose Cauda Equina syndrome as effectively as we ought to is that so many of the symptoms of Cauda Equina syndrome overlap with the symptoms that you expect to find in patients with severe back pain. So when you examine the lower limbs of a patient with severe back pain, if you try and move their limbs and that worsens their pain, that will often masquerade as lower limb weakness. We know that patients who are in severe pain have difficulty synchronizing their urinary stream. So it may be that pain inhibition causes urinary symptoms, another feature of Cauda Equina syndrome. And we know that patients who have back pain, particularly those who are taking chronic long-term opioids or gabapentinoids, end up constipated. So they end up with bowel dysfunction. So there are a lot of features that overlap between Cauda Equina syndrome and patients with severe but simple musculoskeletal back pain. The third reason that we are not as effective as we could be is that the clinical assessment is poor at identifying patients who have Cauda Equina syndrome. And we're going to talk about that a little bit more in a minute. And finally, the gold standard diagnostic test, which is an MRI scan, is difficult to organize for most emergency departments. And in some emergency departments, particularly out of hours, there might not be any access to MRI at all. All of this conspires to result in potential patient harm. And it's no surprise that Cauda equina syndrome is a frequent cause of healthcare litigation. Around 9 in 10 Cauda equina syndrome claims for delayed diagnosis are successful, and the mean compensation paid for a successful Cauda equina syndrome claim is around £400,000. So this is a big problem, even from a mercenary financial point of view. But we've enough of the bad news. Let's talk about how we can do things a little better. So features that might come up in the history that we should be asking about whenever we're considering a diagnosis of Cauda equina syndrome. Probably top of the list is saddle sensory change. This can occur anywhere from the skin overlying the sacrum all the way around the buttocks, between the legs and up around the genitals. It may be a very small distribution, or it might be that whole saddle area that they complain of a sensory change. And that sensory change could be pain, it could be paresthesia, or it could be numbness. It could be subjective, or it could be objective. Any one of those should be sufficient to trigger a concern. Urinary disturbance is commonly reported. This might be retention, but it can also be incontinence, or it can also be present as urinary frequency. So any urinary disturbance is a concern. Bowel incontinence, we've said that constipation is very common, and it's so common, particularly in the back pain population, that I think probably constipation alone can be put to one side, and by itself in isolation shouldn't be a concern, but new fecal incontinence clearly should be. Lower limb weakness, so a motor deficit, a progressive motor deficit, should certainly trigger a concern. And bilateral radicular leg pain, so that's bilateral sciatica. And this snuck into the guidance just a few years ago as being sufficient to trigger a concern for Cauda equina syndrome. It's still a little bit contentious. Really bilateral sciatica indicates a large central disc, which is something that's a risk factor for developing Cauda equina syndrome in the very near future. But bilateral sciatica by itself probably isn't a feature of Cauda equina syndrome at that moment. So we'll see what happens with that as an indication for scanning in the near future. I suspect it's likely to change, but for now, this should be sufficient to trigger a concern for Cauda equina syndrome. So physical examination. So it's often said that there is no individual feature in the physical examination that is sufficient to exclude a diagnosis of Cauda equina syndrome. And that's absolutely true, but it's often said in the context of somebody wanting to explain why they haven't undertaken a thorough examination. And I think often it's overstated. And actually the physical examination is valuable in this group of patients. And it's valuable for a number of reasons. It's very easy in a patient with severe low back pain to become focused on excluding Cauda equina syndrome. But it's important to remember that there are other things that cause low back pain. Some of those might be within the spine. So discitis or invasive lymphoma or cancers slightly further up the spine that might not be included in a lumbosacral MRI. If you have a T10 invasive lymphoma, you won't see that on your scan, but you won't know to scan further up the spine if you don't test for a sensory level and examine the patient thoroughly to start with. There are also lots of causes for low back pain that that start outside of the spine, leaking abdominal aortic aneurysms, ruptured ectopic pregnancies. And if we don't examine patients, we're not going to find these pathologies. We're going to scan the lumbosacral spine and then send them home when that's normal. So examining for an alternative cause. We can't afford to miss any cases of Cauda Equina syndrome. That should be the goal. And in fact, the patients that we can probably do most for are the patients who have very early signs, who are evolving a Cauda Equina syndrome. And we won't pick up these patients if we don't examine them carefully. So we need to examine for subtle neurological signs. We know that neurological deficits can develop where they weren't before, but they develop afterwards. And we know that they can worsen. And so it's important to have some documentation of the patient's baseline neurology at the time they were assessed. Our patient who has simple sciatica, who goes home and may well in the next 48 hours develop Cauda Equina syndrome from their ongoing prolapse of their intervertebral disc, comes back with a Cauda Equina syndrome. And when somebody looks at the documentation from a couple of days before, it will be a medical legal risk if a good neurological examination wasn't documented. And I think this is probably possibly even the most important of the three. Most of these patients are not going to end up with a diagnosis of Cauda Equina syndrome, and we're going to want to discharge them from the emergency department. But most of them are scared. They're scared because of the scale and scope of their symptoms, and they're scared because usually by the point at which they reach the emergency department clinician, they've been told by multiple people that something very dangerous might be happening to their spine. And so if we examine these patients really carefully, they will come to value the assessment and they will value our judgment afterwards. So the doctor who comes in and just does a cursory examination and then tells the patient that they don't think anything serious is happening, even whether that's before an MRI or even after an MRI, the patient will often go home dissatisfied and feeling dismissed and possibly end up representing because they don't have any confidence in the initial assessment. If you get the patient changed into a gown and do a thorough neurological examination, including their reflexes, it only adds a few extra minutes onto the assessment you were going to perform anyway, but it makes a big difference to the rest of the consultation. So findings on examination. So first thing is the examination is made much easier if you are generous with analgesia. So that's ideally at triage, but certainly before you start the history, because by the time you get to examine the patient, you really want them to be as comfortable as possible, because it's very hard to examine the lower limbs of somebody who is in a lot of pain. So generous analgesia. Findings that might be consistent with a Cauda Equina syndrome: lower limb weakness, so a true motor deficit, particularly if it's bilateral. Perianal sensory change. Diminished lower limb reflexes, so that's patellar reflex and ankle jerk. And then we need to talk a little bit about digital rectal examination. I can see we already have a question in the Q&A about digital rectal examination, and I think also about bladder scanning. So digital rectal examination. So it's often said, the textbooks will often say that this is a mandatory part of the assessment of a patient with suspected Cauda Equina syndrome. And you will have clinicians who repeat aphorisms like, if you don't put your finger in it, you'll put your foot in it. But I think practice is changing. So the idea is that the digital rectal examination can be used to assess the internal anal sphincter, that is the anal, by testing anal tone, the external anal sphincter, that is testing anal squeeze, the voluntary component, and also sensation of the anal canal. But study after study shows that the sensitivity of digital rectal examination for Cauda Equina syndrome is very low. And we know that inter-rater variability is extremely high. And combine those two observations with the fact that this is unpleasant for the patient. And I think that the standard of care probably now does not require digital rectal examination in every case of suspected Cauda Equina syndrome. There's also this, the bulbocavernosus reflex, which is recommended by some textbooks. This is an odd idea that requires, so the bulbocavernosus reflex is basically an anal squeeze, an involuntary anal squeeze that results from a reflex when either the clitoris or the glans penis is stimulated. And some textbooks, in all seriousness, suggest that this should be undertaken as part of the assessment of patients with suspected Cauda Equina syndrome. But for various reasons, I think it would be unwise to pursue that line of examination with patients. So digital rectal examination, bulbocavernosus reflex, I think we can leave those out, certainly for most patients. Another thing that we'll often be asked to do is bladder scanning. The idea is that a patient who has early difficulties voiding, so early bladder dysfunction, will have a raised post-void residual bladder volume. So you ask the patient to wee, they urinate as much as they possibly can, and then you do a bladder scan. And we know that if patients have a post-void residual volume of over 200 mils, that is associated with Cauda Equina compression. And it is associated with Cauda Equina compression. But despite that, over half of the patients who have Cauda Equina compression have got less than 200 mils in their bladder after voiding. So completely hopeless as a technique for excluding the diagnosis of Cauda Equina syndrome. My view, and I think it's probably a fairly consensus view, is that bladder scanning can be used as a technique for ruling in the diagnosis. So the patient who presents with back pain and sciatica and has no other features of Cauda Equina syndrome, who you weren't otherwise going to scan, but has an unexplained post-void residual volume over 200 mils, I think that should be an indication for actively excluding the diagnosis of Cauda Equina compression with an MRI scan. But what we shouldn't be doing is using a normal post-void bladder scan result to talk ourselves out of scanning a patient who we were otherwise going to scan. So anyone in whom we want to actively exclude the diagnosis of Cauda Equina compression requires one of these. It requires an MRI scan. There are some hospitals that have, because MRI is a limited resource in the NHS. It takes quite a long time to scan a patient. There aren't as many scanners as we probably need. There is a national shortage of radiographers, particularly MRI radiographers. And this is a resource that at various stages throughout secondary care is protected. So a number of hospitals have started to use limited sequence protocols. So rather than doing a whole MRI of the lumbosacral spine, they'll just take enough sequences to be able to exclude with some confidence that there isn't a large central prolapsed disc compressing the Cauda Equina. And that seems to reduce the scanning time. It halves the scanning time from 19 to 10 minutes. The problem is that although it seems to be reasonably good at excluding Cauda Equina compression, it potentially misses other pathology in the spine. So it might miss a small inflammatory lesion from multiple sclerosis or other pathologies. So some patients will end up going back in the future, perhaps as an outpatient, for a conventional full MRI scan. So there is a risk that the limited sequence scans duplicate work, but in another sense, they speed things along when patients are in the emergency department. Plain films have got no role in the assessment of patients with Cauda Equina syndrome. So timings are a little bit are controversial. So as far as I'm concerned, and as far as I think we as predominantly, as far as I could see, emergency care providers are concerned, the priority should be to make the diagnosis as quickly as possible. The treatment for a patient who has a large intervertebral disc compressing the Cauda Equina is surgical decompression. It is a discussion point amongst surgeons how quickly that decompression needs to happen. There have been a number of studies showing that patients who are operated within 48 hours do better than patients who are operated after 48 hours. And it seems that patients who are operated within 24 hours do better than patients who are operated within 48 hours. And the general view is that rather than there being a safe period of time in which you can delay operating, that perhaps there is some continuous damage that is happening to the Cauda Equina, and that the priority should be to decompress the Cauda Equina at the earliest possible opportunity. Full disclosure, the evidence is not as clear-cut as that might make it sound. There are a number of studies that suggest that the timing of decompression might be less important than is often assumed, and that actually the factors that make the biggest difference to patient outcome are the size of the prolapsed disc and the amount of pressure on the Cauda Equina syndrome, as opposed to the duration of compression. But as far as we're concerned, and as far as the courts are concerned, we should be trying to make this diagnosis as quickly as possible. This is a time-critical diagnosis. And as far as the Spinal Society's advice goes, they say that there's nothing to be gained by delaying surgery, which should be undertaken at the earliest opportunity. And in many surgeons, in many centres, that will mean taking the patient to the operating theatre in the middle of the night. So as far as emergency care providers are concerned, I think we need to make the diagnosis as soon as we can and offer the patients up to the spinal surgeons, and let them interpret the evidence around timings and make the decision about when the patient is best going to theatre. This is just to remind me that making the diagnosis is only half the battle, unfortunately, particularly with the NHS as it is. Because particularly if you're in a hospital that doesn't have a spinal service on site, once you've made the diagnosis, which is difficult enough in many cases, you then have to refer the patient, organise a transfer, and then once the patient gets to the other end, a surgical team has to organise an operating theatre and an image intensifier and a spare radiographer and a scrub team. And actually the delays to get to decompression can be even longer than the delays to making the diagnosis. So the earlier we can make the diagnosis, the faster all the rest of the system can move into action. So what about patients who have a normal MRI? Because only between 5 and 10% of patients that we scan for suspected Cauda Equina syndrome end up having a large disc compressing the Cauda Equina. Another proportion of patients have an alternative structural cause for their symptoms on the MRI scan, which might be compression of a single nerve root. But actually, the majority of patients that we scan have got no structural explanation for their symptoms whatsoever. And I think those of us who work in emergency departments are often guilty of going to see the patient, giving them thumbs up, saying, good news, you don't have the thing we were worried about, you can go home. And we pat ourselves on the back as having done a good job. forgetting that often the patient's concern was never about Cauda Equina syndrome in the first place. And they've got some symptoms that still aren't explained. That might be urinary incontinence or saddle sensory change. And I think we tend to overlook those patients and discharge them home with a job well done. But there have been a couple of studies now that follow up these patients who have normal MRI scans. Between 7 and 10% of them end up having a significant alternative diagnosis for their symptoms, which might be inflammatory cord lesions or benign tumors of the cord or a discitis or a malignancy slightly superior to the upper margin of the MRI scan. So patients who've got objective signs and symptoms, but a normal scan, we should probably just stop and think. At the very least, we should be safety netting those patients to see somebody if their symptoms aren't improving. But a lot of hospitals now are starting to follow these patients up routinely. Often the neurologists will see them to see whether they need further assessment as an outpatient. So take-home messages. So if you've not been paying attention up until now, now is the time just to pay attention for one slide and then collect your CPD points. So the first thing is to consider the diagnosis. So any patient who has back pain or sciatic pain, in your mind, you should be making sure that you ask the questions that are sufficient to exclude a diagnosis of Cauda Equina syndrome. So if you've just got back pain and there are no other concerning features, that's okay. If you've just got sciatic pain, with or without back pain, that's also okay, as long as it's unilateral. But anybody who's got back pain or radicular leg pain with disturbance of their bladder, bowel, or saddle sensory change, or that's got bilateral sciatica, needs to have the diagnosis of Cauda Equina syndrome actively considered. And actively considering the diagnosis means examining them carefully, acknowledging the limitations of the physical examination, and having a low threshold for MRI scanning. And as much as we would like to be able to say that we can take a patient who's got bilateral sciatica, examine them, and confidently say that this patient doesn't need an MRI scan, I don't think the standard of care allows us to do that at the moment, and probably won't in the future either. So we need to have a low threshold for MRI scanning. And we should need to do the right thing for the patient, even if that makes it difficult for us and difficult for the system. So even if that means potentially transferring the patient to another hospital, or it means arguing with a radiologist or arguing with whoever we need to push the case with, then that's what we ought to do. And the therapeutic relationship is really important when dealing with these patients. When the MRI scan is normal, that's not necessarily the end of the job. We need to safety net these patients, and we possibly need to be following them up routinely. And the same goes for if the MRI scan is abnormal. If they've got Cauda Equina compression, that's not the end of the job either, because the job is finished. Well, we have reached an important stage once the patient has surgical decompression of the Cauda Equina. So we can't celebrate once we've got the diagnosis. We need to push the patient on to the next stage. Just a postscript, really, because about system considerations, because we all want to do the right thing for our patients, but that is sometimes difficult given the system that we're working in. The Cauda Equina syndrome is recognized as a significant risk across the healthcare system. I think everybody in the know knows that we are not doing these patients justice. GIRFT, the Getting It Right First Time program, and the Healthcare Safety Investigation Branch have both highlighted this as a concern. And there is, over the next few weeks, there's going to be a new national pathway. So that's a new guideline that will tell us how to manage patients with suspected Cauda Equina syndrome, all the way from the patient presenting with symptoms through to their rehabilitation after surgery. So look out for that coming over the next few weeks. It's going to be published. It's coming from GIRFT and NHS England. So thank you very much. There's a younger version of me on Twitter. So any of you who are interested in high consequence diagnoses in the emergency department, please feel free to follow me there. But thank you very much for spending your Tuesday evening with me here.
Thank you, David. Really interesting subject. And we've definitely got a few questions in the questions and answer box. So I'll let you have a look at that. Just trying to share my screen. There we go. So it's always nice for our speakers to get some feedback. So please leave David some messages in the chat box. Any specific questions and answers that you've got pertinent to his presentation, please drop into the question and answer section. We'll let David have a couple of minutes of digesting those and formulating some responses, hopefully. Is my screen going? So for those of you who it may be coming up to the time when you're getting the curly finger from the HCPC, then please check out our YouTube channel, which is full of videos, useful guides, how to use our product, how to pop your CPD into your portfolio, all that kind of good stuff. It is all on there to make your life so much easier. As we already mentioned, CPD certificates for those of you who are premium members of CPD.me, and the recording will be dropped into your portfolio probably tomorrow. You'll also get an in-app notification when this arrives, allowing you to go in and complete that reflective cycle of reflecting upon what you've learned tonight, how it's going to influence and possibly change your practice for your patients. We're going to give a couple of shout outs now to some events which we are sponsoring. So the Faculty of Pre-Hospital Care Scientific Conference is taking place in Edinburgh, beautiful city, 16th and 17th of March this year. There are limited tickets available for that. It is always really good looking at the cutting edge of what's new, what's coming out, speaking with authors of new papers, so on and so forth. So please do check that out. That is on the Faculty of Pre-Hospital Care website. Please do. The team from CPD.me will be up there as well, so you'll be able to say hello to Andrew and Amy. So do check that one out. The next event that we're supporting is the St Emlyn's Wild event. This is an event that you will not have ever been to before. It's the first event taking place in Coniston. That's going to involve camping. It's going to involve lots of medical activities, team building tasks, all taking place over the Lake District, where you'll have the opportunity to do some climbing, abseiling, walking, so on and so forth in between. It's a proper immersive get busy, get into the wilderness for everyone's mental health. Everyone having a good time, socializing, networking, as well as doing some learning. So do check out the St Emlyn's website for that. Alternatively, cpdme.com/wild, and all the details about the instructors, the event, the costs are all on there. So do check that one out. So question time. David, have you managed to have a quick look at some of the questions?
Yeah, there's loads of them. So I just shall I try and just spread my time amongst all of them?
Yeah, I would.
Do I press answer live?
We'll talk it through.
Okay, so first one at the top of the screen, I can see digital rectal examination. I think we've dealt with that in the presentation. Low inter-rater reliability and not sufficiently sensitive, unpleasant for patients. People will tell you to do it. My view is that I don't do things to patients that I don't think are going to be helpful, but sometimes you've got to pick your battles sometimes. But yeah, routinely I wouldn't do it. Rob Rose asks if you can have the slides. I don't mind. Up to you, John.
Yeah, if you're happy to share them, if you want to email them across to the team and we can fire them out.
Okay. What kind of subtle neurological signs should we be looking for? This is Billy O.D. Could there be behavioral changes, or are we talking motor sensory exclusively? So the nerve roots that make up the Cauda Equina innervate the bladder, the bowel, the sexual organs, and the lower limbs. So we wouldn't be expecting behavioral changes because we're a long way from the brain. So we're just talking about sensory and motor changes predominantly, but also, of course, the bowel and bladder symptoms as well. Susie's asking about using a paperclip to examine the perianal area. So ideally, we should be using fine point discrimination. So that's ideally a neurotip. But I realize that neurotips probably don't hang out in emergency departments very often. I better not recommend using a paperclip for someone's perianal area, but you've got the general idea that yes, you should be using something that's got a slightly pointy edge, because as well as crude touch, because that's not sufficient by itself. But I don't think I've ever actually, maybe I'm giving too much away, I don't think I've ever actually done that in an emergency department. Working in an ED is all about compromises. So ideally, yes, if you're talking to a neurologist, certainly. Rebecca, working in primary care, sent the patient to the emergency department with pins and needles across the abdomen. So that's interesting. So pins and needles across the abdomen, to me, suggests that there's something happening above the Cauda Equina. So because we're talking, we're sort of onto the thoracic nerve roots. If we've got what sounds like a sensory level on the abdomen, which is why it's important to examine patients, because otherwise you're not going to pick that up. It may well be that that patient didn't have Cauda Equina compression, but had some kind of thoracic cord compression. I don't know what kind of operation they had, but yes, definitely look for a sensory level if you can. So that's just testing sensation on the abdomen. Takes 2 seconds. What analgesia do you prescribe when you see back pain on the screen? I guess the textbook answer is that analgesia should be multimodal and tailored to the individual patient. So not every patient is appropriate for non-steroidal anti-inflammatory drugs, etc., etc. But I think the principle should be to hit their pain hard. I find with a lot of acute pain, if you get on top of it early, the WHO pain ladder is fine for chronic pain and trying to address pain over a period of time. Start simple and then become and then move on to the opiates. But with severe acute pain in the emergency department, patients are much happier if you get on top of their pain early on. And I think there's some reasonable evidence that if you treat acute pain effectively up front, it's less likely to become a chronic pain problem in the future. So I give them as much as I can, bearing in mind that not every patient can have everything. Susie's asking about cervical compression. So I must admit, I'm slightly out of my comfort zone in terms of cord compression. I would have thought if you're thinking that someone truly has cord compression, so that is you're worried that they've got myelopathic changes, so upper limb changes or bowel bladder disturbance from a cervical cord pathology. I think that patient should be going to an emergency department as well. That might not be correct, but that's what I would advise if anyone asked me professionally. The Cauda Equina is particularly vulnerable because its blood supply is not as good as the rest of the cord. So it's probably a slightly more time-sensitive diagnosis, Cauda Equina compression, than cord compression. But I think cord compression needs a prompt diagnosis and a plan from a spinal specialist as well. How am I doing for time?
We've got about 5 minutes left.
I feel like I'm rattling through, but I'm not sure whether I'm doing what you want. But
no, it's good.
So how would a secondary diagnosis like a tumor present acutely concurrently with some type of event or trauma? I'm not quite sure I'm completely following the question, but ultimately anything can cause Cauda Equina compression. So I've talked about intervertebral discs because that's the most, disc prolapse is the most common cause of Cauda Equina compression. But a tumor can present in just the same way. So can a big abscess from a discitis or a hematoma after an operation or trauma. They might be treated slightly differently to the disc prolapse causing Cauda Equina compression, but the presentation might be very similar. Is there a common patient such as by age or sex? The honest answer is I don't know, but neither of those features are going to be sufficient to help guide our decision making. They're not going to be strong enough associations. One thing you do find amongst older patients is that they will often have a slightly different pathology called canal stenosis. So over time, they get a narrowing of the vertebral canal, and they might present with similar features to Cauda Equina syndrome, but they usually present much more slowly, and their history will be over months and months and months. Definitely I would discuss those patients with somebody who's on top of the literature when it comes to spines, but they often don't get treated with the same degree of urgency as the patients who've got a sudden event causing Cauda Equina compression. Still doing okay for time?
Yeah, still good. 3 minutes.
This feels like an exam. Do we have a pathway for unilateral symptoms? This is from Deborah, who's a physio in virtual triage. I believe we do, as in my trust does. So this is for patients who don't have enough features that are indicative of Cauda Equina syndrome, but they do have severe unilateral symptoms. So the patients that trouble me most are the patients who've got a new foot drop. So they've got a significant objective motor deficit that's almost certainly being caused by a disc pushing on a lumbar nerve root. So those patients ideally do need to be seen in a day or two. So hopefully everywhere has some kind of acute spinal pathway, but I realize that might not be true for everybody everywhere. Victoria asked about success of surgery. I think that's really highly variable. Some patients do make a complete recovery. Sadly, I think I'm probably safe saying that most do not, even when everything happens promptly and as it should. So this is a devastating thing to happen to a patient, even if they get optimal platinum treatment once they present. And Victoria also asked, is there guidance for people who work pre-hospital? I don't know. There's probably lots of people here that are better placed to answer that question. And I would hope that there are, just because I'm sure that paramedics are seeing patients with back pain, and the decision to convey or not, I would hope would at least to some extent be informed by whether or not patients have got any of those red flag features. So if there isn't guidance, maybe somebody here might be in the mood to think about designing some. And then Adam, similar question really for people who are working pre-hospital. So I don't know about what the men's stroke exam is, but FAST certainly won't really help us. Again, we're talking lumbosacral nerve roots, so we're talking lower limbs, bowel or bladder. So I certainly wouldn't be reassured by a normal FAST exam. And Paul asks a good question about what symptoms would lead to a pre-alert, and I think none. I don't think any of the features of Cauda Equina syndrome should prompt a pre-alert to the hospital. I don't think it'd be a bad idea as you drop the patient off to say that you're worried that this patient might have Cauda Equina syndrome, and the people working in the emergency department then have to work out what other things they're balancing. But this is something that needs to be diagnosed within hours, not minutes. So it's not like our major trauma strokes where really it's every minute that counts. We're making this diagnosis over hours, so I don't think a pre-alert is necessary. But equally, if you're coming and dropping somebody off in a department where it's a 9-hour wait to be seen and you want to tap the doctor in charge on the shoulder and tell them what you're worried about, I think that would be very welcome. I'm conscious that we've hit 9 o'clock and I'm testing people's patience now.
Well, it's your time. You're the speaker, so entirely up to you. There is a couple of threads from a couple of questions about patient positioning. So from an ambulance point of view, transporting the patient in, what's the best position would you suggest?
Yeah, and I don't think there's any good evidence to help guide that. I have the same question in my mind. Is it acceptable to let this patient sit in the waiting room, for example, if they're comfortable enough? I don't think there's enough evidence to tell us we should do anything any differently to what you would normally do. So however you would safely safely and comfortably convey a patient, I wouldn't change anything just because you're worried about Cauda Equina syndrome.
Sure. There we go. Well, I think we'll wrap it up there because judging by the questions that are still coming in, we could still be here at 10 o'clock tonight. And I'm conscious that people have probably had a shift. Thank you, David, for giving up your time tonight for everyone. Really insightful. Lots of great feedback coming through on the chat. So we'll summarize all that and get that over to you. But for now, I just want to say a big thank you once again to David for giving up his evening. Thank you all for participating and being awesome as always. If you're working, please stay safe, have a very safe shift, look after yourselves, look after your colleagues, look after your patients. If you're not, please recharge, refresh, ready for the next time you are in. Take care, everybody, and look out for our forthcoming webinars on the website or via the app.
Thank you, everyone.
Thank you very much.